Yes, okay. My name is Sergey Bodnia. I am a cardiologist and endovascular surgeon at Dzhankoy Central District Hospital in Crimea, where I lead the Department of Endovascular Diagnostic and Treatment. I'm happy to be here at this international forum, and I want to sincerely thank the PLENARENO organizing committee and personally Ms. Catherine Reed for this innovation. Today I will speak about stent thrombosis in acute coronary syndrome. This is a topic that sits at the intersection of two questions every interventional cardiologist must answer every day. What makes a patient dangerous before we even start? And what makes a procedure dangerous once we begin? I will show you our data on risk factors, and I will propose a practical prevention strategy based on our clinical experience. My goal is that you leave this session with something you can use in your cath lab tomorrow. Let me begin with my topic matters. Stent thrombosis is not the most common complication in interventional cardiology, but it is among the most catastrophic. When it occurs, mortality reaches 20 to 40%. The patient who walked into hospital or came in by ambulance and survived a heart attack can die not from the infarction itself, but from the stent that was placed to save them. In acute coronary syndrome, the risk is substantially higher than in elective PCI. The patient is already in profoundly prothrombotic state. The lesions are more complex, more unstable, more unpredictable. The procedures are done under time pressure, and the margin for error is narrow. Despite the advances of the last decade, drug-eluting stent with thinner struts, more potent plate agents, better imaging guidance, stent thrombosis still occur. Our study was decided to understand why it's occur in a regional hospital setting, and what we as operator and as a team can to do prevent it. Our study have two clear goals. The first was to identify the risk factors for stent thrombosis in our patient population. We separated these factors into two groups from the very beginning. Patient-dependent factors, things that come from the patient's biology, history, and clinical condition, and operator-dependent factors, things that reflect our technique, our decisions, and the procedural complexity we face or create. The second goal was to build a practical prevention strategy from these findings. Not theoretical frameworks, but something usable, something a cardiologist can apply before the next ACS case. To conceptual foundation, our approach is simple. We cannot always change the patient. We cannot under the diabetes, their calcificate coronaries, their history. But we can always improve our preparation and our technique. And that is exactly where the leverage is. Our study was a retrospective analysis for all patients with acute coronary syndrome who underwent percutaneous coronary intervention at our center between 2021 2024. In we analyzed 2,260 patients. We identified all cases of stent thrombosis using standard criteria, both definite and probable events, according to the academic research consortium definition. Each case was analyzed in depth: clinical history, procedural records, angiographic images, and medication that were reviewed. All identified risk factors were classified into two categories: patient-dependent and operator-dependent. And we specifically look for patients of co-occurrence. The question was not just what factors were present, but how did they combine. Among our patients, stent thrombosis occurred in 17 patients. That's 0.8%, approximately one in every 132 cases. This number is consistent with published literature, where rates in contemporary death series range from 0.5 to 3% in 1 year. I want to make one thing very clear before we go further. 0.8% sounds like a small number. It's not. It's events worth treating emergency. Several were fatal. Every single case caused harm to a real person, and in many cases was potentially preventable. That is why they studied them so carefully, and the patterns we found were sticking in their consistency. Here is the patient-dependent risk factor we identified across the 7 stent thrombosis case. Male gender was 82%, age over 65 years, type 2 diabetes mellitus, arterial hypertension, dyslipidemia, active smoking, STEMI. The most severe presentation of acute coronary syndrome was present in 58% of cases. Left main or proximal LAD involvement, the most technically demanding on clinical consuectinally coronary territories, was found in 65%. Chronic kidney disease, and this of number I want to remember, 31% of patients had inadequate or absent antiplatelet therapy before the procedure. 31%. Broadly, 1 on 3 patients with stent thrombosis had no received proper dual antiplatelet loading before PCI. This is completely preventable. This is protocol problems, not biology problems. Now the operator-dependent factors, the variables that reflect our decision in our technique. Severe coronary calcification was present in 44% of cases. Calcified vessel are mechanically resistant to stent expansion, and incompletely expanded stent is one of the most reliable documented cause of both early and late thrombosis. Bifurcation lesson. This requires specific, carefully planned technique, and when managed improperly, they behind prothrombotic geometry. In stent restenosis in 20%. Incorrect stent sizing, also 20%. A stent that is too small makes inadequate wall contact, One that is too large causes vessel wall injury and paradoxal thrombosis, and errors in antiplate regimen, wrong drug, wrong dose, missed loading in 14 days. That last group, the most important, 14% of our stent thrombosis events were associated with antiplated protocol errors. This should not happen. When we have clear standardized protocols, they do not happen. When we do not, they do. This is center slide is our presentation. Let's look at this carefully. Of the 17 patients who developed stent thrombosis, 16 of them, that is 94%, had at least on one patient-dependent risk factor and at least one apparat-dependent risk factor simultaneously. 94%. This is not a coincidence, this is a pattern. And the pattern tells us something fundamentally important about how stent thrombosis occur. It's not random, it's not bad luck. It's the majority of cases, a predictable collision between a vulnerable patient and technical problems. A patient with diabetes on suboptimal antiplatelet therapy who receive a stent that slide understand in a severe calcificate proximal AID. This is not an unpredictable catastrophe. This is a foreseeable event, and foreseeable events can be prevented. For clinical practice, the message is direct. If we find the high-risk patient before the procedure, and if we simultaneously optimize our technical approach, we break this combination. We stop the collision before it's happened. What can we do on the patient side? For active and semi-urgent cases, we have time to prepare. Glycemic optimization reduce the prothrombotic milieu created by poorly controlled bits. And it started making a difference with hours of intervention or just days. High intensity statin therapy should be initiated or confirmed in every CS patient, not just for plaque stabilization, but because statin also modulate platelet reactivity. Smoking cessation, even brief, immediate cessation before an elective or procedure that function measurably. And above all, dual antiplate load before PCI must be standard, documented and never assumed. In our cohort, 31% of stent thrombosis patients had inadequate pre-procedural antiplate therapy. This is a system fail, and it has a system solution. A mandatory pre-procedure checklist that confirm loading has been given. For high-risk anatomy, left main, proximal LID, the discussion for extended antiplate therapy should be made before the cath lab, not after a complication. On the operator side, several specific technical improvements directly reduce stent thrombosis risk. Intravascular imaging, IOS or OCT, should be used routinely in high-risk situation. Left main disease, severe calcification, bifurcation lesion, long segments, and any case where stent sizing by angiography alone in uncreating. Incorrect stent sizing was present in 20% of our thrombose cases. With routine IVUS or OCT guidance, this number should approach zero. For severely calcified vessels and in ACC, you will encounter them often. Do not attempt to fully expand until you have not properly prepared. Rotational atherectomy and endovascular lithotripsy exist precisely for this reason. A stent that cannot fully expand should not be left in place. For bifurcation lesson, plan the technique before entering the room. Where you will use a two-stent or single-stent approach. Improvisational bifurcation PCI leads to suboptimal geometry and prothrombotics anatomy. And always confirm the antiplate prescription, the right drug, the right dose, the right timing before even single procedure. Based on our findings, we developed a simple pre-procedure checklist. It has two sections: patient risk profile and procedural complexity profile. This is not a formal validated risk score with sensitive and specificity that I want to be transported about that. It's a structured clinical tool built from the patterns we observed in 7 real cases that any interventional cardiologist can apply in 2 minutes before every ACC procedure. When both sections show multiple concurrent risk factor, which, as we have seen, happens in 94% of stent thrombosis cases, the protocol automatically requires additional caution. Mandatory intravascular imaging, confirmed antiplatelet loading, extended dual antiplatelet therapy planning, and if needed, her team review before a complex decision. This tool requires no software, no special technology, and no additional cost. It's require only a structured habit of thinking before each case begins. Let me briefly place our result in the context of published data. Our stent thrombosis rate 0.8%. It's at our center compared well with the major contemporary trials. Horizont IME reported 2.50% at the 1 year. Examine trial reported 1.2%. Comfortable IME reported 1.0%. We are the lower end of published range, but I want to be direct. 0.8%, it's now our goal. Our goal is 0. The gap between where we are and 0, that's exactly what this analysis is about. Our 7 defines the roadmap to close the gap, because if 94% events were predictable and the predictors are actionable, the most of them were also preventable. I won't be fully transported about the limitation of this work. This is a retrospective single-center analysis. We can identify association and patterns. We cannot provide causation. We had 17 cases of stent thrombosis. This reflects the fact that modern treatment is effective, but it means that formal multivariate regression analysis is not statistically possible with the sample size. The checklist we propose is derived from clinical observation, not from a prospective validated study. There was no independent adjunctional or angiography findings. Not all patients had complete long-term follow-up data, and our findings from a regional center in Crimea may not be directly generalized to very different healthcare setting. A prospective multi-center study applying a structured pre-procedural checklist and measuring its effect on stent thrombosis rates is the necessary logical next step. In conclusion, stent thrombosis is our cohort of all patients, accurate rate of 0.8%, consistent with contemporary published data. In 94% of those cases, patients with an operator-dependent risk factors were present simultaneously. This is the defining finding of our study. Stent thrombosis is not random. In most cases, it is predictable. And what is predictable is, in principle, preventable. The practical implications are clear. Assess both the patient and the procedure, not one without the other. Identify the dangerous combination before the case begins. Use intravascular imaging in high-risk situation. Confirm antiplate loading without expansion. Prepare calcified and complex vessel properly linting. Structured combined approach, good clinical judgment plus discrete technical execution is the most powerful prevention tool we have in the real world of IC intervention. 3 things to take home from this presentation. First, always assess both the patient and the procedure together. Neither one alone predicts stent thrombosis well. The combination of a high-risk patient and the technically difficult of suboptimally executed procedure. That is where the danger lies. Second, focus on what you can change. Pre-procedural antiplatelet loading, glycemic control, correct stent sizing with imaging guidance. This as they are always your direct control before first wide process installation. A structured combined approach is not a theory, it's a practical habit. Build it into your pre-procedure routine. Use a checklist, make it a part of your team culture. The patient who benefit will never know they were on the high risk list. They will simply go home. Thank you for attention. I'm ready for questions and happy to discuss an aspect of our methodology, our technique, or clinical approach in more detail.